Hi, I'm Marty Cohn, and welcome to episode 3 of Grace Cottage Hospital's Healthcare Matters, a monthly show that brings you timely information about health-related topics. Grace Cottage Family Health and Hospital is an independent healthcare facility located in Townsend, Vermont, just 17 miles from Brattleboro. Among its services are primary care, rehabilitation, and 24/7 emergency care. For nearly 70 years, Grace Cottage's mission is to promote wellness, relieve suffering, and restore health. October has been named Breast Cancer Awareness Month. On this show, we will be discussing women's health screening for breast and cervical cancer, as well as osteoporosis. Our guests are Dr. Ewa Arnold, a primary care provider at Grace Cottage Hospital, and Emma Higley, who is the Diagnostic Imaging Manager at Grace Cottage Hospital. Welcome, Dr. Arnold.
Well, thank you.
Well, let's get right into this breast cancer and stuff. According to the American Cancer Society, 1 in 8 women will be diagnosed with breast cancer in her lifetime. To your knowledge, is that a correct figure?
So that figure does seem to be correct. The average American woman, so a woman of average risk without extraordinary risk factors, has about a 12.5 to 15% chance of developing breast cancer, which is pretty significant. Breast cancer is the most common non-cutaneous, so non-skin cancer in American women and in women worldwide. It is also the second cancer killer in North America and the first worldwide, the first being lung cancer in women in North America. Now, who is this risk? So obviously women. Women have about 100-fold or 100 times more likely to develop breast cancer than men. Then there are people that are at an extraordinarily or a much more higher of an average risk, which are women with a family history or personal history of breast or ovarian cancer, women that carry a genetic mutation called the BRCA1 or BRCA2, the BRCA genes or the breast cancer gene, or women that have received irradiation to the chest area, especially at the young age of 10 to 30 years old. So those women are at much higher risk. Then there's certain things that put you at a slightly higher risk of breast cancer, dense breast tissue being one of them. That comes independently. Dense breast tissue is a risk factor for breast cancer, but also because of limitations of our screening methods, dense breast tissue is much harder to image. Other than that, things like prolonged estrogen exposure, natural as well. So women that have gone through their periods early or started periods early on in life have a prolonged period of estrogen exposure, so they're at a higher risk. Women that are obese, especially in the perimenopausal time period, so women that have a BMI greater than 30 seem to have a higher risk of breast cancer. That's because our fat cells make estrogen, actually. Then there's a controversy about women that received hormone replacement therapy, especially for a prolonged time. That seems to increase your chances of breast cancer slightly. And then women that have not had babies. Then there's lifestyle factors that increase chances of breast cancer. Those are lack of exercise, smoking, and excessive drinking. Those are pretty much risk factors for everything.
Right.
Not just breast cancer, cardiovascular disease, just risk factors for disease. And then things that are protective against breast cancer, and that is physical activity, getting at least 2.5 hours of moderate to intense physical activity in a week decreases your chance of breast cancer, as well as breastfeeding seems to be protective.
All right. Wow. There's a lot of risk factors there. But what are the techniques for detecting breast cancer?
So in an average risk woman, there's only one technique that has been proven to help detect. So that's mammography. Mammography is the only screening test that is currently approved. So we do mammography, which is an X-ray imaging study of the breast. There is other tests that serve as adjuncts to mammography or follow-up for abnormal testing, and that is ultrasonography. So an ultrasound is an ultrasound study like we do to pregnant women and to look at the baby of the breast, and that is helpful in women with breast tissue as well as women that have had an abnormal mammography finding. The other test is an MRI, so magnetic resonance imaging. That is a very sensitive test, so it picks up sometimes a little bit more than a mammogram would. That has been shown to help, along with mammography, in women, once again, with dense breast tissue and women that are at a higher risk of breast cancer. So that's women that have a higher than 20% lifetime risk of breast cancer. And we use this risk stratification tool to calculate your lifetime risk of breast cancer. Then there's the simple things that we can do at home. So at home or in the office. So clinical breast exams and self-breast exams have not actually shown in studies to be beneficial in breast cancer detection. Oh. And they increase risks of false positive rates, meaning people sometimes find things that are actually that don't end up being cancer but lead to further testing. However, the World Health Organization, while it might not recommend taking the time apart to do your monthly self-breast exam, it does recommend that women know their own breast geography, so are aware of what feels normal and what feels abnormal. And I have, in my short practice, I have had women that have found their own breast masses more than on one occasion. So I really strongly advocate that women know their own breast geography. At the same time, a clinical breast exam, which is what I would do in the office, is a good time to discuss that with patients. So I still at least have a discussion about that and maybe help women examine their own breasts during our physical exam. These have also been shown to be helpful with breast cancer detection in resource-poor settings, so settings where mammography is not available.
So these tests, though, in your mind, these are reliable tests?
So a mammogram is a reliable test, or has been shown to be reliable. When we look at how good a test is, we look at the sensitivity and specificity of a test, which are big words. Sensitivity meaning how many of positive findings, or how likely are we to miss a negative finding. Right. So a mammogram is only, and the data differ from study to study, but about 80 to 90% sensitive, meaning that we have to be aware that it does miss about 10 to 15% of abnormalities. So it does miss some cancers. No test is 100%. Right. It is also about only 90% specific, meaning that there's a fair number of false positives, women that are going to be called back for additional images or for further studies. That does not necessarily mean that you have a cancer, and that's where the adjunct tests that we talked about come in handy.
So if you get something that's irregular or something's detected, you have another test?
You have another test. So about 10% of people that have a mammogram will have a callback. That callback means will be either for additional imaging or for another test, a different view from a mammogram, or even a biopsy. So 10% of people will get a callback, so 1 in 10 women. If you consider a woman that's getting a mammogram every year starting at age 50, that woman over a 10-year period will have about a 1 in 2 chance of getting a callback. Wow. These callbacks can be really anxiety-provoking for women, if you can imagine. So I try to counsel my patients saying, hey, this is a possibility. Only about 10% of those people actually end up having cancer. So I think it's really important for women to know, hey, this is a possibility. This is part of screening. And if it's cancer, we'll try and fight it.
Now how often should a woman be tested for breast cancer?
So this is a loaded question because everyone has a different opinion about this. Okay. At the very least, I'm going to say an average risk American woman, so a woman with average risks without the additional, especially the really bad risk factors that we talked about, should be screened at least starting at age 50 to age 75, right, going at least every other year. Now, everything else, so women between ages 40 and 50 can also be screened, and you can screen as often as every year. That is controversial because that increases rates of false positives, so those anxiety-provoking callbacks that we talked about. So I think it's really important for women to take to talk to their caregiver, their doctor, nurse practitioner, physician assistant, OBGYN, whatever, and make the decision to whether screen more often or earlier with their doctor. So we call that shared decision making, and I think that is really, really important.
Okay, definitely it's important to communicate with your doctor.
Yes.
So let me just shift gears for a quick sec and go to cervical cancer. What same kind of questions. What are the techniques for detecting cervical cancer?
So cervical cancer is cancer of the cervix, which is kind of the end of your uterus. It's a little donut-shaped structure that we see during a pelvic exam. The way we screen for that is using a pap smear. The pap smear is collected during a pelvic exam. What we do is we initially do a pelvic, do a speculum exam, look at the cervix, and then collect the cell sample using either an endocervical brush. We collect the cell sample, send it out for pathology, and a pathologist looks at the test. Currently, as of the last maybe 7 to 10 years, we also co-test for HPV, which is the human papillomavirus, and that just makes that test a better test. So we're looking for abnormal cells, and we're looking for the presence of this human papillomavirus, which is the virus that's linked to development of most cervical cancers.
So the pap smear has been around for a while. That's a reliable test.
This is an extremely reliable test.
Okay.
So the pap smear actually itself on its own, I don't know, you probably don't know because you're not a woman, but
You got me on that
I got
one,
you
doctor.
on that.
You got me.
So way back, 7 to 10 years ago, we were doing pap smears regularly every year, and that's because we were not co-testing for the human papillomavirus. Right now, we are co-testing, which makes this test a much better test, and that means we can spread out pap testing for 3 to 5 years. So without the HPV added on, the pap smear is about 50 to 65% sensitive, which means it misses about 35% of cancers,
Right.
whereas with the HPV co-testing, it is 95.9 sensitive.
Wow.
So this is a really good test. So the negative predictive value of this test, which means if you have a negative test result, how likely are you actually not to have this disease,
Right.
is 99%. So this is like as good as we get.
Wow. Okay.
It's a good test.
Okay, that's good. So in this particular case, you were talking about callbacks and things like that. Is this a possibility of someone detecting something irregular or?
So when an irregularity is detected on a pap smear, it depends on what the irregularity is. Your body is able to clear the HPV virus on its own. So typically, if you have a really low-grade cellular abnormality or no cell abnormality but a positive HPV, we will just repeat that pap smear in 1 year. However, if an irregularity is greater than that, we will refer you for a colposcopy, which is just a better pap smear. Essentially, where we stain the cervix with different stains that will highlight irregularities and lead to a possible biopsy. And that will be even a more reliable test, and that will be treated appropriately.
Okay, so all right, now here's a question that I had. You're a primary care doctor. Aren't these tests that you've been talking about usually performed by a woman's gynecologist?
So I would say no, not typically. I think all of us internists, family physicians, nurse practitioners, physician's assistant, we're trained in preventive healthcare, and I think this is a really important part of prevention. So I, myself being a woman, I do a lot of woman exams. I really enjoyed the shared decision-making part of this, as well as doing the exam. So while I rely on my gynecology colleagues for referrals and follow-ups on abdominal exams, this is something that's certainly a part of my practice, and then I think all of our family doctors practice, and something that we really enjoy.
Okay, well, so there's always a lot of talk about health insurance and things like that, but the exams and the screenings that you're talking about, are those covered by insurance? How does that?
So yes, right now under the Affordable Care Act, or Obamacare, As long as that is in place, most screening exams are covered. So typically, the Affordable Care Act will cover annual physical every year in women up until the age of 65, and that will include a mammogram starting age 40 every 1 to 2 years, as well as cervical cancer screening in sexually active women.
Okay, so it's covered then. All right, final advice. What do you want to?
Final advice?
Final advice. What do you want to tell the viewing public?
I'm going to say minimize your risk factors. So I think prevention is really important. So eat well, exercise, sleep 8 hours a day, don't stress, and maybe just maybe get your physical exam at least once a year, if not every other year, please.
Okay, thank you, Dr. Arnold, for taking the time to be on the show. We'll be right back with Emma Higley, who's the Diagnostic Imaging Manager at Grace Cottage. But first, this brief message from the Mayo Clinic about how men can also battle breast cancer. We'll be right back.
True or false? Men get breast cancer.
True. There are approximately 2,000 men diagnosed with breast cancer in the United States every year.
Mayo Clinic medical oncologist Dr. Catherine Ruddy says men with a family history of breast cancer or a BRCA2 gene mutation are at a higher risk for the disease, and she says it tends to occur in older men. However,
men of any age can have breast cancer.
Dr. Ruddy says male breast cancer often occurs near the nipple. Symptoms may include a lump, dimpling or puckering, redness, or a discharge.
So nipple changes, nipple pain should be evaluated. Any change in the breast tissue needs to be assessed by a doctor.
Tests and treatments for men are similar to those used for women, including the use of mammography to investigate changes in breast tissue.
I think the most important thing for men to realize is that they can get breast cancer, so they should not ignore any abnormality they detect in the breast tissue.
For the Mayo Clinic News Network, I'm Jeff Olson.
Welcome back to Grace Cottage Hospital's Healthcare Matters, a monthly show that brings you timely information about health-related topics. Our guest is Emma Higley, and Emma is the Diagnostic Imaging Manager at Grace Cottage. Welcome, Emma.
Thank you.
Okay, so we just heard about breast cancer and cervical cancer, but one other subject I wanted to cover with you is osteoporosis. What is osteoporosis?
Well, osteoporosis is one of the most common forms of bone disease. It's a low bone mineral density, and it causes fractures, low impact fractures, specifically of the lumbar spine, the hips, and the wrist. And coincidentally, it affects 80% of the patients who come up with it are women. So it's very, very important to proceed with screening.
So women are mostly with osteoporosis. What are the risk factors for osteoporosis?
Well, it mirrors the other health conditions that Dr. Arnold was speaking to, but exercise, weight, drinking, smoking. There are some risk factors that, candidly, nobody has control over. You don't have control over your sex or your race, your family history. So there are other risk factors that the person cannot change.
But is age, is it happen when you get older?
It is more prevalent in the older population. However, it is seen in children, and it is seen in men.
Yeah.
There was a bone, I want to say this correctly, there was a measure, act passed by Congress that ensures that women age 65 and older and men 70 and older should have the screening every 2 years.
Wow.
And it guarantees payment for that.
Wow.
Because they thought that it was that important to follow up on.
So how is osteoporosis diagnosed?
Well, it's a simple screening. It's called the bone density test. You have it done in our case, at the hospital. I'm sure that there are clinics around as well. It's painless. It's very comfortable. It's very fast. The radiation is quite minimal. It's similar, I would say, to going through the screening at the airport. You just simply lie down, relax. You put into several positions, and we acquire some images, specifically of the hip and the lower back. And the computer has set parameters that we test everything against to determine the risk factors for the patient.
Now, and how long does the test take?
Probably from start to finish with filling out the paperwork,
Right.
because there's a screening process.
Right.
15 minutes.
15 minutes.
Yeah.
That's all?
That's it.
Wow. Okay. Well, that's pretty incredible. Now, you mentioned that women are mostly doing this, but what about men? Are men? I mean, is this something that I should be worried about?
Actually, you should be.
Okay.
I'm
Another
sorry
thing
to
for me
say
be worried
that.
about,
I'm
huh?
sorry to say that. Statistics say that 1 in 8 men will be affected by this.
1 in 8?
Yes. Yes.
Oh, okay.
So you should have the screening as well. As I mentioned, the Act guarantees payment for men 70 and older.
Okay.
For
Okay.
Medicare.
I've
You're
got-
not there yet.
I'm not there
I
yet.
know.
I've got a few. Okay, that's good.
You're free.
All right, but let me ask you this. Now that you got me thinking, so once you get this 15-minute bone density scan or test,
Scan.
scan,
Yeah.
scan. What should you expect?
Well, it'll take a couple days for the results to come back, and the results will be provided to your physician, and your physician will let you know the results. If you're within the specified ranges and you're not diagnosed with osteopenia or osteoporosis, you just charge on with your normal course of life. There's always a chance that if your results indicate osteopenia, which is a precursor to osteoporosis, your physician may put you on some medication or vitamin supplements. I'm not a physician,
Right.
but a course of treatment could be put into place.
So, but would you increase the number of times? I mean, so I come in in 2017, and I'm getting this bone density scan. When do I have to come back again for another scan?
If you have a normal scan,
Yeah.
it would be 2 years.
Oh.
If you don't have a normal scan and you're put on a course of treatment, your insurance will pay for you to come back and have them again at the will of your doctor to follow and see if treatment is working and if your numbers are improving.
Wow. So, and in terms of going to be tested, you mentioned 70 years old. Okay, so I've got a few years
Yeah.
there. But is that the magic number? Or should women start earlier?
Well, it is recommended with the Medicare Act anyway that age 65
Wow.
is when you need to start. However, I mean, postmenopausal women, certainly, if there's an indicator, and there could be many indicators, say I just simply bumped my arm and I broke my wrist,
Right.
and say I'm 50,
Right.
that is cause for the doctor to order a bone
Wow.
density test, because it is showing that there's a possibility that my bone mineral density is too low and that I need to catch this and hopefully correct it.
Uh-huh. Now, the bone density scan machine. How often do you get to use this machine?
We screen patients every single day with
Whoa.
this unit. Yes, this is our exact unit. We left the lights on. It's usually dim light, very comfortable setting. But for the purpose of acquiring the picture,
Right.
we left the bright lights on.
Sure.
But it's very comforting once you get in there, and the position you put the patient in is quite relieving too. It's
Right.
nice.
And it's something. Again, it's only 15 minutes.
Yeah, and the positioning, this part of it probably is 5 at tops.
Wow.
But you fill out a screening form,
Right.
everything's entered into the computer, have a little chit chat.
Right. But you're doing these every day. Wow.
Yeah.
That's pretty impressive. Now you mentioned this is something that is covered by insurance.
It is. It is
So,
covered.
okay, so this is so important that insurance companies make a point of paying for it.
It's so important that the government decided they wanted to pay for it.
I want to thank you so much for being on the show.
You're very welcome.
I also want to thank our guest, Dr. Ewa Arnold, and I have to do a shout out to Roland Boyden, who's doing all the magic behind the camera. He makes it seem so easy. I also want to thank BCTV for helping us bring this show to you. Our next episode is going to talk about preventative medicine. That's important. And how to pay for it. That's also important. If you have any questions, concerns, or ideas for future shows, send them to info@gracecottage.org. info@gracecottage.org. I'm Marty Cohn. Thanks for watching.